So this mini lecture is going to be looking at anticoagulation, specifically in the context of treating atrial fibrillation. So there's a little bit of a physiology review here. I'm going to go over some of these concepts just to review some of these major points that kind of put things into perspective from the pharmacology angle. And so basically what we're looking at is we're looking at the counterbalance between hemostasis and the production of clots. And essentially what happens is, excuse me, is that there has to be some type of inflammatory event that essentially produces these clots. And in some cases, this inflammatory event is obviously normal, but in some cases it becomes pathological. And depending on the size and the severity of this clot, and if it actually completely occludes this vessel, that's kind of the distinction between, normal physiology and disease. When these clots become really large, and if they become dislodged, that's really kind of setting the stage for pathology. And so central to these clots are platelets, also known as thrombocytes. Excuse me. And they're cell fragments. They're derived from megakaryocytes, and they've got a relatively short half-life. They only live about 8 to 10 days. And in terms of the platelets, they basically play major roles in the formation of these clots. And so when you talk about the clotting cascade or the clotting process, these platelets can adhere to each other. They can activate other platelets and have effects on the endothelium. And of course, they can aggregate. And when they aggregate, that's when these clots get bigger and bigger, and that's when pathology starts to manifest itself. And so central to kind of this inflammatory hypothesis in terms of the vascular system, we can revisit a hypothesis back in the 18th century called Virchow's triad, which kind of sounds like a Russian mafia organization, but it's really looking at the interplay between endothelial cell injury, abnormal or turbulent blood flow, and this notion of the blood being too thick or hypercoagulated. And of course, within the physiology, there are normal control mechanisms that will inhibit the formation of clots, and there are control mechanisms that will favor the formation of clots, depending on what's happening at the local environment and what overall physiologic effect is needed. Okay. And so the way these thromboses or these clots can form could be physical damage, such as a wound. But for this lecture, we're really going to talk about physiological damage or pathophysiology that results in the formation of clots because of hypertension, and this is uncontrolled hypertension, turbulent blood flow, which is kind of happening within the atria. Those atria are not contracting at the proper speed, and in many cases are asynchronous. And so you get this kind of pooling or this regurgitation of blood within the atria. And that basically can form a hypercoagulated state that's really able to clot a lot faster than normal. Other things, bacterial products, cholesterol, toxins, and radiation, these are all things also that can induce the formation of clots, and we'll come back to these concepts throughout the curriculum. In terms of having blood that's essentially too thick, these thrombi can form due to inherited reasons. Some of the more commonly encountered genetic reasons behind hypercoagulated states are listed here on the left. And then they can also be acquired over time. So certain drugs can induce a hypercoagulated state, autoimmunity to various proteins, autoimmunity to heparin molecules, autoimmunity to certain certain phospholipids, can produce these acquired hypercoagulated states. And so the outcome is the same: blood is too thick. And so central to this blood being too thick are the formation of these thrombi or these clots. And sometimes these clots can propagate, they can get bigger, sometimes they can move, sometimes they can shrink or resolve by themselves. And in some cases, they can actually become vascularized, and so this is due to essentially the inflammatory cells that infiltrate these clots and actually lay down a vascular network, and the process of angiogenesis can occur. Excuse me. Likewise, as these clots move, they become embolic. So an embolism is a solid, liquid, or a gas, but it's a mass that moves through the circulation. And so then, therefore, thromboembolism is a clot that has migrated out of the initial site and has moved somewhere else. And so, atrial fibrillation can produce thromboemboli that can move throughout the systemic vascular network. Pulmonary embolisms are typically caused by deep vein thromboses, and these typically occur in the lower leg extremities, and break off and migrate into the lung compartment. Okay, and so in terms of pharmacology, we're going to treat all these coagulation disorders with the drugs that we're going to discuss. And so, what is coagulation? It's the change in the properties of blood. And so we're talking about the physical properties of blood changing from a liquid phase to a gel or a clot-like viscous type material. And so anticoagulation therapy or anticoagulation measures will keep blood in this liquid phase so that these clots do not get bigger and cause pathology. And so if these clots travel in the coronary circuit, you can produce a myocardial infarct. If they travel into the cerebral circuit, they can produce a transient ischemic attack or a stroke. And so these clots are definitely problematic, and really, excuse me, the main therapeutic approach to managing these patients with atrial fibrillation is to prevent these clots from forming. All right. And so the coagulation cascade is really complicated when you first learned it. It actually makes more sense when you apply the drugs to it. So I think in this new curriculum, it might actually be a little bit easier. I don't know, we'll find out. I do want you to realize that when you're looking at the coagulation cascade, and this is just an excerpt from one of the pathways. Essentially, you have Roman numeral whatever, and then it gets converted into Roman numeral A. And so A is active, and so this is an example. So prothrombin is Roman numeral factor 2, and then thrombin, which is biologically active, is factor 2A. And so the way in which prothrombin gets activated to thrombin is through another factor. And so typically in the coagulation cascade, one factor activates the other, and that's why it's a cascade. And so like any other biochemical pathway, you need an enzyme, you need a substrate, and you need a cofactor. And these three different ingredients, so to speak, will basically produce this coagulation cascade, which basically produces all of these prothrombotic type factors. And so thrombin is essentially the central key player to this whole cascade. And so this really just kind of shows you the machine where one activated factor activates the second factor, and then that activated factor activates the third factor, and so on and so forth. So this is what that coagulation cascade pathway looks like. You can further subdivide the different components to the pathway into the intrinsic and the extrinsic, as well as the common pathway. And so just some kind of unique attributes about these different pathways. The extrinsic pathway is, the tissue factors are essentially generated outside of the circulatory system. Okay, the intrinsic pathway, these factors get basically activated or exposed to negatively charged molecules, which could be bacteria, proteins, or enzymes, glass, foreign substances, and then this instigates a specific cascade of the following factors listed here. But central to the coagulation cascade is factor 10, Roman numeral 10, which is shown here with an X, because factor 10 actually is the only factor, okay, that actually activates prothrombin into thrombin. And once this thrombin molecule or factor becomes biologically active, thrombin can actually activate the pathway in at least 3 different other sites. And so here you see this blue box thrombin. This is active thrombin activating factor 11, factor 8, as well as factor 5. Okay, and so factor 10, which is shown here in the center, and thrombin, which is also known as factor 2, are really kind of the key players, and of course make our first pharmacologic drug target that we'll discuss in a couple of moments. Sorry. And so there's lots of different outcomes to this coagulation cascade, and a few of them are highlighted in red on the next slide. We've got antithrombins, okay, which actually reduce the activity of thrombin and some other factors. We've got proteins C and S, which are also kind of your vitamin K dependent factors that inactivate several other coagulation factors, and your tissue factor pathway inhibitor, TFPI. And so there are built-in control mechanisms that restrict or inhibit the coagulation cascade. And so what we also can do from a pharmacologic standpoint is utilize those same concepts and have drugs that can mimic these effects. And this is clinically significant, as you'll see in the latter part of this lecture. Okay, and so the drugs, or the factors and the proteins that restrict the coagulation cascade, so they would inhibit the cascade that was pictured here, are shown here. And so the main ones really are antithrombin as well as proteins C and S. And so these are the ones that actually have a kind of a well-defined pharmacologic mechanism that we're going to discuss in a lot more detail, in the next aspect of this lecture. Okay, so that's kind of a quick 10 or 12 minute overview of the physiology of coagulation. Let's go now into the pharmacology. Okay, so there's several drug classes, that affect the coagulation cascade pathway. And so what we're going to do is we're going to focus on these 4 for this Ruth Barzich case. We're going to talk about heparin molecules, as well as heparin-like molecules or synthetic heparin molecules. We'll talk about vitamin